All right, everyone. Well, we are going to go ahead and get started here. So I want to thank everyone for spending your time and joining us here all today for this side event. My name is Jay Gagliata. I am the Policy and Communications Officer with the International Network of People Who Use Drugs, and I'm very excited to be facilitating this side event for you all today here at the 64th Commission on Narcotic Drugs. So I'm going to pass it over to Judy Chang, the Executive Director of INPUD, in just a second for some opening remarks. Before I do that, though, I just wanted to go over a couple of housekeeping items to consider over the next hour during the webinar. Um, First and foremost, you see on your screen right now instructions on how to join the language interpretation services. We have interpretation available to Russian, Spanish, and French. So please feel free to join in that now. And thank you to all our interpreters for offering your services today. I also want to let everyone know that this event is being recorded and also being currently live streamed to Facebook as well. So just to let you know that that is occurring. And we hope to have some time here for Q&A at the very end of the session. We have a great panel of speakers to present to you today. We want to have everyone give as much time as possible, but we certainly want to hear your input at the end of this as well. So we would ask that in the interest of time, that if you have any questions you'd like to submit to the panelists, you please use the Q&A function in Zoom to submit questions during the session. And at the end of it, we will go through some of the best questions that we receive and pose them to all of our panelists for whatever time remains. And finally, we definitely encourage people to interact in the chat. Please feel free to introduce yourselves and say where you are joining in from. We would also just remind everyone to please be respectful and to use appropriate language, and to remember that this is a UN side event and that we are all trying to treat each other equally. So thank you all again for being here. We're very excited, and without any further ado, I want to pass it off to Judy Chang, who is the Executive Director of INPUD.
So welcome everyone to this side event. We are the evidence, community-led responses on decriminalisation, COVID-19 and harm reduction. So INPUD, we're the global peak body representing people who use drugs, and we work to protect the health and defend the rights of our community. So we have been adversely impacted by the war on drugs, having our right to health, non-discrimination and self-determination continually undermined. There can no longer be any doubt that systemic and fundamental changes are needed. But we are seeing winds of change, one clear example being Norway. Drug decriminalisation models, as we will hear from panelists today, are not the same around the world, and a new INPUD report documents the oft overlooked lived impacts of ostensibly progressive drug policy reforms, which in many cases still continue to perpetrate harms. This is because drug policies and programs continue to be developed without meaningful community involvement. So community-led responses are critical to decriminalise efforts, as they have always been to harm reduction, and more recently, as we've seen during the COVID-19 response. We commend UNAIDS for placing community leadership as a key pillar within their new 5-year strategy, and we emphasise the need for funding and political support to make this vision a reality. So the history of community-led activism and advocacy has not been acknowledged or celebrated enough. And in 2020, INPUD produced and published a report, Taking Back What's Ours, available on our website, which was a documented history of the movement of people who use drugs. So one of the peers interviewed said, and I quote, "It's time we no longer content ourselves to be invited to others' table. It's time we started inviting them to our table." So I just want to thank everybody today for coming to our table. I also want to thank the HIV Legal Network, African Network of People Who Use Drugs, the Norwegian Ministry of Health and Care Services, and UNAIDS for co-sponsoring this event with us. And for, of course, all the participants for joining our discussion on how we can enter, a new era where people who use drugs are at the center of advancing legal and policy reform. I also want to acknowledge the Robert Carr Fund and Love Alliance, funded under the Dutch Ministry of Foreign Affairs, who prioritise funding critical, life-transforming, community-led work. And finally, I want to acknowledge Jude Byrne, who is a founder of INPUD and a fierce community advocate who passed away in March this year, but she unfailingly dedicated her life to shifting power towards the community. And I hope in this side event and following this, this is something that we can all commit to doing. So thank you.
Thank you very much, Judy, and very well said. So without further ado, I'd like to pass it along to our first speaker, who is Annie Madden, coming from Australia. Annie is a PhD candidate from the University of New South Wales and was one of the principal authors on the INPUD decriminalization report. And she's going to go over the report, the methodology behind it, and a couple of our key findings from the report here. So Annie, take it away when you're ready.
Okay. Hi, everyone. Good evening, good day, good morning, wherever you are. I'm assuming everyone can hear me all right at this point. Great. Okay. So thank you, Kim, for bringing up my slides. So as was said, I was one of two consultants that was employed by INPUD to work on the research and the report that we are launching today. I don't have very long to present to today, so I just wanted to let everyone in attendance know that I have prepared a slightly longer version of these slides that we will make available to attendees after this, which does go into a little bit more detail on some of the findings from the report and from the research. So, don't feel the need to sort of take all this in really quickly. We will, you will have an opportunity to be able to look at those slides at your leisure. So with that said, I'll just get into it from here. So next slide, thanks. Yeah, thank you. So there we are. There's the cover of the report. The report, as you can see, is titled Drug Decriminalisation, Progress or Political Red Herring, Assessing the Impact of Current Models of Decriminalisation on People Who Use Drugs. Before I go any further in talking about the report, I just want to acknowledge my co-consultant on this report, which was Pascal Tanguay, and co-author as well, and of course Judy Chang, who was a co-author on this. I also want to take this opportunity to acknowledge the study participants who gave very generously of their time. And of course, this report, this amazing report we're launching today, would not have been possible without their commitment and their energy. So thank you to the participants. Next slide, thanks. So I want to talk a little bit about why we did this research. So as many of you will be aware, over the past decade, there have been increasing claims that we are moving towards a critical turning point in international drug policy. Many are claiming a virtual new dawn in drug policy reform, citing recent moves towards decriminalisation by now almost 50 countries as evidence of this progress. But despite several recent reviews on the impacts and outcomes of decriminalisation models, none have specifically included the perspective of those most affected by these reforms, which of course is people who use drugs. So it was in this context that INPUD identified the need to conduct a peer-driven research project into the impacts of current approaches to decriminalisation from the perspective of people who use drugs. We had two key aims in doing this research. First was to bring a critical lens to claims of progress in this space. And secondly, we wanted to interrogate concerns that reforms are frequently too narrowly focused on cannabis reform alone, and/or often simply replace one set of sanctions for another without paying sufficient attention to issues of injustice, stigma, and human rights violations. Next slide. So how did we go about doing the research? Well, as I said, it was a peer-driven research project. We took a two-stage approach to this. The first was a literature review, and that identified existing models of decriminalisation that are being utilised, the countries and jurisdictions involved, and key aspects of their implementation. And we use this to inform our selection of our focal countries for stage 2. And stage 2 was a series of qualitative interviews. We used a purposes sampling approach that ensured a balance across different regions, coverage of different models, and a diversity of views. We then did a total of 8 in-depth qualitative interviews that were at least sort of an hour long. Some were considerably longer, and they were conducted with 12 respondents from countries including Costa Rica, Estonia, Kyrgyzstan, the Netherlands, Norway, Portugal, Uruguay, and Vietnam. The respondents were all people working at organisations representing people who use drugs, and the majority of the participants were people who use drugs themselves. We used a framework for our approach to the sort of the models of decriminalisation that are underutilisation in the world. We used a model that has been developed by Hughes et al. In work that they have done for the Irish government. We slightly adapted that model. Their model has 6 key models of decriminalisation. We slightly adapted that to land on sort of 5 key models that we based our report around. And you can look at the full report for more information on that and a full reference for the work from Hughes et al. Next slide. So the key areas that all respondents were asked to provide their views on. We looked at sort of 6 of these key areas or topics, if you like. The first one was policing, detention, and other sanctions. And this other sanctions included threshold amounts and administrative sanctions and fines. Second was looking at stigma and discrimination. The third issue was surveillance and privacy. Fourth was access to health and social care. 5 was meaningful involvement, and the last section was the way forward. Thank you. Next slide. So what did we find? Just very broadly and quickly now. So what we found was that despite some positive impacts on policing and interactions with people who use drugs, decriminalisation measures have not necessarily or consistently translated into better outcomes for people who use drugs. This is largely because the models adopted are not full decriminalisation, and they continue to utilise strategies of control and surveillance and/or to pathologise people who use drugs as victims needing treatment and rehabilitation. Many of the decriminalisation approaches continue to be based on arbitrary quantity thresholds that do not recognise the reality of drug use or dependence, with extremely negative outcomes for people who use drugs. Many countries have simply replaced criminal penalties with administrative sanctions, and the most common of these are fines. But fines are often too high, and when they're combined with poverty and other factors, they can lead to more, not less, criminalisation, including charges, arrests, arbitrary detention, and more incarceration and imprisonment. Whether the punishments imposed on people who use drugs are administrative sanctions or criminal penalties, all participants ultimately agreed there is a need to remove these sanctions completely. Next slide. Further findings were that although stigma and discrimination may have decreased in some settings since decriminalisation, once again, these outcomes are ultimately being undermined by ill-designed models of decriminalisation. These ill-designed models have given rise to increased monitoring and surveillance, including use of routine urine drug testing without consent to pressure and coerce people who use drugs into decisions and actions. Decriminalisation laws and policies have contributed to facilitating access to harm reduction services in some places. However, this is not the case everywhere. And in some countries, there was no real or lasting improvement in harm reduction or access to other health and social healthcare services. Despite decriminalisation, there are ongoing problems with drug dependence treatment in many countries, including serious concerns about the continued forced compulsory treatment of people who use drugs in Asia in particular. Finally, it was noted that decriminalisation policies are being designed and implemented with little or no consultation with people who use drugs. And even where consultation has occurred, advice is not always taken seriously. Participants felt there was still much to do towards the meaningful involvement of people who use drugs. Last slide, thanks. So what did we recommend? What did INPUD recommend based on these findings? We have five key recommendations. First is that all models of decriminalisation must fully decriminalise people who use drugs. That means removing all administrative sanctions, mechanisms of monitoring and surveillance, coercion, and punishment for use and possession of drugs. This includes ending compulsory detention where it exists. Secondly, that people who use drugs and their community-led organisations must be involved in all stages of the reform process, including the design process and the provision of accessible and credible information to community on any proposed reforms or changes. Third, that full decriminalisation must also include specific strategies to end stigma and discrimination among people who use drugs and ensure adequate funding for such interventions. Fourth, that full decriminalisation must include scale-up and expansion of access to harm reduction and social care for people who use drugs relevant to the local context and needs. And finally, once full decriminalisation is adopted, it should only be as a step on a continuum that has as its clear and ultimate goal the full legal regulation of all drugs in a timely manner. Thank you for your time. That's all I've got time for today, but very happy to take questions either later on, as Jake said, or after the event today. Thanks.
Thank you so much, Annie, for all of that. There's certainly a lot of information from this report, and we encourage everyone to go to INPUD's website after this to check out the full thing in detail. And I will include the full deck of Annie's slides in our post presentation packet to all the attendees, so you can see even more in-depth analysis on that. So thank you very, very much. We're very excited to be sharing this today. So next, I want to move on to Richard Elliott, who is with the HIV Legal Network in Canada. So Richard, whenever you're ready, you can please take it away. Thank you.
Great, thank you, Jake, and thanks to INPUD for organizing this session and the opportunity to co-sponsor it, and congratulations on this report, which I think is really important. What I wanted to spend a few minutes talking about, I think, complements the INPUD report nicely because it's a bit of an update on advocacy that is happening by civil society and developments that have been happening in Canada as we build momentum toward decriminalization. And I think the report from INPUD and the points it makes are quite timely and indeed quite aligned with what civil society is proposing in the Canadian context. Next slide, please. So over the last 5-year period for which we have detailed data, we have seen more than 470,000 drug arrests made in Canada. And according to our analysis, more than 70% of those were cases in which charges were laid for personal possession or simple possession, that is possession for personal consumption. Next slide, please. What has been happening at the same time, of course, is the worst overdose epidemic in Canada's history, and that has only exacerbated and intensified calls for change to policy. And there is growing recognition and public support for decriminalization to at least some degree in at least some form. And of particular note, last summer, the Canadian Association of Chiefs of Police, so police chiefs from across the country, also released a report in which they recognized that prohibition and the criminalization of simple possession was not working and that there was a need for transformative change. Next slide, please. However, there are different conceptions of what decriminalization means, as has just been pointed out by Annie and in the INPUD report. And some of those are, in our view, insufficient and unsatisfactory. So the proposal from the Canadian Association of Chiefs of Police, welcome though the recognition is that criminalization is a problem, in fact, proposes to maintain some of the very same problematic provisions that INPUD has just highlighted in their report. That is, while it would remove criminal sanctions for simple possession for personal consumption, it would nonetheless maintain potentially other kinds of sanctions, including fines, and police would play a role in their view of how decriminalization would work in diverting people to treatment and other support services. There has also been an important development from the Federal Public Prosecution Service, which is responsible for prosecuting drug offenses in most jurisdictions of the country, a guideline that prosecutors should only be taking forward prosecutions for simple possession in what they consider to be, quote, the most serious cases where there are other kinds of concerns at play in the facts of the particular case. And they too would envision or are suggested to divert cases that they aren't prosecuting to other alternative measures from the criminal justice system. So these are important recognitions of the fact that criminalization is causing harm and needs to end, but they're half measures in response at best. Next slide, please. There is also federal legislation that would embody, if it were to pass, which is a very real question as to whether it will, this diversion approach that directs, at least in the case of simple possession charges, people to be diverted out of the criminal legal system. From the perspective of civil society, of course, including people who use drugs, there are any number of problems, and they are nicely laid out in the report that Annie has just presented as to why this continued coercive approach and response to drugs, and in particular to simple possession, carries a number of problems and ultimately is insufficient if we are talking about decriminalization. There are a number of human rights concerns that remain. It continues the surveillance and control of people who use drugs. And as we have already seen in Canada and in so many other jurisdictions, there is a disproportionate impact of criminalization now on some of the most marginalized and on racialized people, particularly Black and Indigenous communities and people in Canada. And there's every reason to think that that would continue under a decriminalization light approach. Next slide, please. So from the perspective of civil society, including a loose coalition of organizations, including groups of people who use drugs, there is a need for a more robust and fuller definition and understanding and vision of decriminalization that includes a number of different features. In particular, first and foremost, it requires the removal of all criminal sanctions and all other penalties or coercive interventions in cases of simple possession of all drugs. And this, I think, is quite consistent with the recommendations that INPUD has just presented. And in particular, there are specific things that are of concern that must be removed from the operation of the law as part of a full decriminalization agenda, including an end to any administrative penalties, mandatory health assessments, fines, appearances before dissuasion commissions, confiscating people's substances or paraphernalia, imposing restrictions on people's travel or contact, the turn to drug treatment courts as a quasi-coercive alternative to criminal sanctions, or any other kind of coerced or involuntary treatment or ostensible health measures, sometimes things that are not in fact health measures being passed off as such. It will also be important to automatically expunge previous convictions that people have received for simple possession or other penalties related to other breaches of orders that may have been attached to simple possession, like probation orders, bail conditions, etc. And of course, it will be important to deal with how police are operating on the ground and educate police and set strict rules about when it is that police are having interactions with people in relation to drug offenses or perceived drug offenses. In addition to decriminalizing, the resources that are currently devoted to prosecuting people for drug possession charges should be redirected to other kinds of evidence-based health and social services that remain inadequate at this point. Next slide, please. But there is also a question about going beyond simply the decriminalization of simple possession, recognizing the reality, of course, that people, including people who use drugs for various reasons, will share with friends and acquaintances. Sometimes people will purchase on behalf of others, in part to reduce the risk of coming to the attention of police and all of the negative consequences that can flow. And of course, as we know, and as has already been mentioned, it is not uncommon that some people will be sharing or selling specifically as a means of livelihood or to support their own use. And it is not a good use of public resources, and it is actually quite harmful to continue to criminalize this kind of activity. And so the vision that civil society is developing is one that includes the decriminalization of the sharing or selling of limited quantities of substances. Next slide, please. So how might this be achieved? Well, there are two ways in particular, both of which are being pursued. The first is that under the existing drug law in Canada, which is federal law applicable throughout the country, the federal Minister of Health actually has the statutory authority to exempt any person or class of persons from any provision of the federal drug law if it is in the public interest. And there is a call on the federal health minister, endorsed by more than 180 organizations across the country at this point, for her to proactively issue an exemption that would apply nationwide to all people, exempting everyone from prosecution for simple possession under the current law. In the longer term, what is needed, of course, is legislative amendments to that law, the Controlled Drugs and Substances Act, to remove the criminalization of simple possession entirely, but also to amend the trafficking provisions to limit the criminalization of small-scale selling and sharing. In either of these approaches, the question of quantities, of course, naturally and quickly arises. And I think here the point to make, and we can have a longer discussion about this later, is the importance of decriminalizing, at the very least, possession of quantities for personal use and potentially for small-scale sharing and selling. The definition of those quantities has to be done carefully and in a rights-compliant way that includes, of course, the perspectives of people who use drugs, and that will evolve over time, taking account of the realities of people's drug use and of conditions in the drug market. Last slide, please. Finally, just to note that at least with respect to the decriminalization of simple possession, that is possession for personal consumption, all states parties to the UN Drug Control Conventions have complete freedom to fully decriminalize simple possession, a proposition that some years ago was controversial, but is now widely recognized that this flexibility does in fact exist in the Drug Control Conventions. Things get a little more complicated when we're talking about decriminalizing small-scale sharing or selling. Nonetheless, there is still some degree of flexibility, albeit not the same degree with respect to simple possession. And it is imperative that states, including Canada, take advantage of that flexibility to the maximum extent, as a step toward a larger discussion about what Annie has ultimately mentioned, that is legal regulation of all substances in the interests of public health, human rights, and other considerations. So let me stop there and pass it over to the next speaker, and thanks for your attention.
Wonderful. Thank you so much, Richard, for that brilliant presentation. A lot of really interesting, great info about right there about what's happening in Canada. Before we move on to our next speaker, I just want to acknowledge one that we're having a bit of troubleshooting going on with our French translation, working to fix that right now. And there were a couple of questions in the chat regarding translations of the Decrim report. I just wanted to confirm that we will be having translations of the report coming in several languages forthcoming. That will take a couple of weeks to put together, but we will have those. So next, I'd like to pass it over to Torbjorn Breck, who is the Senior Drug Policy Advisor at the Norwegian Ministry of Health and Care Services. We're really happy to have someone representing the government of Norway here to talk about this today. So we'd love to pass it over to you, Torbjorn, and take it away whenever you're ready.
Thank you, Jake. I'm ready if you are ready, if you can hear me. We do, yeah. Colleagues, dear friends. First, I have no slides. Excuse me for that. Firstly, let me thank INPUD, Jake and Judy, for inviting us to this important event, and it's an honor for me to speak here. Secondly, I hope you can accept my excuses for the very boring title I have given this statement, namely the consensus model, a mutual interaction between the authorities and civil society. And by that, I intend to shed light on not the Norwegian model, but on the conditions under which civil society operate and can make their voices heard and influence on policy decisions. In the Nordic countries, we have a long history of strong grassroots movements, and NGOs have played a decisive role in forming our welfare system. Many of the first NGOs that received public financial support had tasks related to social security. It could, for example, be for the homeless or for people with substance use-related problems. The organizations developed a closeness to groups they worked for and could, and still, act as ears and mouthpieces for these groups to the authorities. The close interaction between the public and voluntary sectors in Norway is often highlighted as a characteristic of our democracy model, also called the consensus model, which refers to the mutual interaction between the authorities and civil society organizations. There are several informal and formal forms of contacts and arenas, such as the many councils, the boards, and committees that function as dialogue forum between authorities and voluntary associations at national, at regional, and at local level. This great importance Norwegian authorities attach to civil society participation is also reflected in Norwegian development aid policy by stating that an active and independent civil society is a premise for a democratic and sustainable development of society, and that more than 20% of the development aid assistance budget goes to civil society organizations. Moreover, user participation is now a statutory right in Norway and is thus not something the services apparatus can choose to deal with or not. A relevant example of this is that 2 out of 10 members of the Drug Reform Committee, they were representing people who use drugs. User is thus defined as a person who uses relevant services in one form or another. It's also meant for people who use drugs. User participation can take place at the individual, service, and system level and is regulated by acts. It is a law. It's an obligation. The municipality shall, for example, ensure that representatives of patients and users are consulted in the design of municipalities' health and care services. This has been fundamental in the government's project to create the patient's health service and placing the service receiver in the center under the slogan, "No decision about me without me." As you already might know, there is an initiative towards decriminalization in progress in Norway, and with a final decision in Parliament on the 3rd of June this year. The model we will have to come back to if that could be of interest at a later stage. Many actors have pushed and defined this process, and among these are definitely representatives from civil society and especially some specific user organizations. For many years, representatives for people who use drugs was not existing, but invisible and stigmatized. Thus, their voices were not heard. During the last decades, however, we have registered a renewed interest in civil society in general. This development is explained by several factors, and as part of this wave, so-called user organizations have also grown up. One reason for this specific group's growth was probably introduction of a rapidly widespreading of medically assisted treatment. In the beginning, and typically for such movements, they were formed by some very engaged individuals, and those who argued for decriminalization, they were lonely riders, and more often made fool of than taken notice of. Gradually, however, the support for help instead of punishment for use and possession for personal use, call it decriminalization if you prefer, it has gained more and more public acceptance. There are several reasons and motivation behind this national and international movement. What nevertheless is a fact is that the progress in Norway has been accelerated by some very strong and brave voices from user organizations, people who use drugs or have used drugs or representing the people. And the lessons learned is that the interaction between authorities and user organization, the arrangements for users' involvement, the user's professionalism is pointing out a way forward for further collaboration and development. I thank you.
Thank you very much, Bjorn. It's certainly great to hear that kind of partnership being discussed openly between people who use drugs and the government on these types of policies. So thank you very much for being here and for making that statement. So next I want to pass it off to our next speaker, Richard Ninina Azwe, who's coming to us from the African Network of People Who Use Drugs as a program coordinator. So Richard, whenever you are ready, you can please start your presentation. Hello, Richard. Oh, he's coming.
Thank you, everyone. So, I would like first of all to acknowledge all the speakers before me. It was a wonderful presentation. So, hello.
Hi, Richard. We can hear you. The connection is a little bad. Maybe if you can just turn your video off, that might help.
Hello.
Yep, we can hear you.
Yeah.
Richard? Seems like we're having a couple of connection issues with Richard. So while we kind of troubleshoot those, why don't we move on to our next speaker and final speaker, Laurel Sprague from UNAIDS. And I'll work with Richard to try to get him back online and we can end with his presentation. If that is all right with you, Laurel.
Yeah, absolutely all right. Let's hope we can get Richard back. I think we're all really eager to hear what he has to say. So I'll be brief. I know we have a short time to get together. Let me start by saying a real thank you to INPUD for organizing this and for the work to create this report, which is incredibly helpful for civil society and communities, but also, I need to say, incredibly helpful for UN agencies and organizations. So I think we can talk further about how to take this forward in our work as well. So what I've been asked to speak to you about today is our new Global AIDS report that was passed by the UNAIDS Program Coordinating Board just about 2 weeks ago on the 25th of March. And if I could go directly into the next slide. The new Global AIDS strategy is for the years 2021 to 2026, titled End Inequalities, End AIDS. It was developed by the UNAIDS Secretariat and its 11 co-sponsors, of which I saw that UNODC, our good colleagues from UNODC, at least are also on this call today. We received inputs from more than 10,000 stakeholders from 160 countries in the process to develop this strategy. We are grateful to the community of people who use drugs and other community and civil society networks and organizations for the substantial feedback on the strategy that helped to shape its key messages, the goals, and the targets. Let's go directly to the next. So you see here an overview of the slides, but what I'd like to do is go to the next slide, which is my last slide. It's the only one I'll really speak to. And here I'd like to draw your attention to the targets from the Global AIDS strategy that are most important for our discussion today. And these are that 90% of people who inject drugs have access to comprehensive harm reduction services, integrating or linked to hepatitis C, HIV, and mental health services. Next, that less than 10% of countries criminalize possession of small amounts of drugs by 2025, which is one place where this report will be particularly useful as we push countries to meet that target properly. The new global AIDS strategy also calls to intensify and redouble efforts to scale up comprehensive harm reduction for people who inject drugs in all settings, including needle and syringe programs, OST, opioid substitution therapy, naloxone, interventions for alcohol and non-injecting drug use, as well as prevention, diagnosis, and treatment of TB, viral hepatitis, community-led outreach, and psychosocial support. Now, let me say, we know that globally and in every region, we are far behind in reaching these goals. In many places of the world, harm reduction services face legislative and financial barriers for reaching their clients with quality services, even more so when it comes to women and young people who use drugs and also to people who use stimulants. UNAIDS started to actively call for decriminalization in 2015. Questions on laws and policies that criminalize drug use are part of the global AIDS monitoring from countries that we receive yearly. We see that the progress with decriminalization is very slow. The new targets related to decriminalization are not likely to be achieved unless networks and organizations get recognized as key partners of government in drug policy reform, completely in line with the recommendations from what INPUD has just shared. And unless these networks and organizations obtain substantial resources for their accountability, advocacy, and monitoring work, we will not be able to achieve these targets. We have to face the reality that the engagement excuse me, the engagement of the community of people who use drugs meets obstacles because of stigma and enormous levels of criminalization. In many places, people who use drugs still have to hide their identity and are not allowed to register their organizations. This is a huge barrier to our ability to move forward. UNAIDS commits to supporting the community of people who use drugs in their harm reduction advocacy and drug policy reform efforts. We know this community is a remarkable source of expertise on a wide range of policy and technical questions, and we're grateful for the opportunities we continue to have to partner with you. For example, in order to monitor the world's progress toward the decriminalization target, we will need to work with the communities of people who use drugs to define what small quantities are and how to measure the change, not only on the legislative level, but to ensure that this is implemented. Very much in line also, Richard, with the work that you're doing in Canada. We will engage with community experts on these questions. We're also going to increase our efforts in mobilizing funding for community-led monitoring and advocacy, as well as for community-led harm reduction services. As you can see from the slide, this is also reflected in another target that 80% of service delivery for HIV prevention programs for key populations and services for women are to be delivered by community-led, key population-led, and women-led organizations. And I want to assure you that these commitments will be routinely monitored. And so I look forward to our partnership together as this strategy moves forward from being published and agreed and published into reality for people on the ground. Thank you.
Thank you very much for that, Laurel. It's fantastic to see this new UNAIDS strategy and how progressive and strong it is when it comes to decriminalization compared to what has traditionally been coming out of the UN body. So really fantastic to see this work. Thank you. So do we have Richard back who can finish us off with his presentation? Richard, are you there? Still do not seem to be able to hear you if you're talking. He just dropped off the call. Back on. Sorry, everyone, just bear with us for 1 second. Richard? Can you hear us?
Thank you.
Hey.
Yes, I can hear. Hey.
Hey, how you doing? We can hear you again.
Yeah. So we are the evidence community-led response on decriminalization, harm reduction, COVID-19, with an African scan. So starting on decriminalization, the single convention on narcotic drugs was a health burden faces for people who use drugs. But when you look in the article Prohibition Drug Policy in South Africa, Versa recommend that the Single Convention of Narcotic Drugs should be challenged, prioritize rights and health, and that the personal use of drugs be decriminalized. INPUD had a regular discussion with the Deputy Minister of Social Development who now promote decriminalization, encouraged former President Morton to support decriminalization. So also in harm reduction, we've seen African drug user networks are now beneficiaries of in-country global fund with harm reduction in drug use in CCM, Dubai, Kenya, some networks are global funds in East Africa, like INPUD, Uganda Harm Reduction Network.
Oof. Sorry, Richard, it seems that you have maybe cut out again. If you can hear me.
So drugs and COVID-19. So there's a specific impact of COVID-19 on people with drugs. We saw increase in gender-based violence from the female partners of people with drugs due to lockdown, loss of income as people who work in the informal sector, which reduced due to lockdown, increase in mental health issues, increase in police harassment, issues for homeless people with drugs in lockdown. But a total of 50,000 USD was granted to people with drugs and talks across the African continent in the following countries: Burundi, Cameroon, Cote d'Ivoire, Kenya, Mozambique, Tanzania, Rwanda, Uganda, Zanzibar, and Zimbabwe. This was the first time that the rapid response fund granted to people who use drugs, and these grants were for networks who
It appears that Richard has unfortunately dropped off the call again. Yeah, we are sorry for everyone for the connection issues here. It appears that we're just having a couple of issues with Richard on his end, but I'm glad we were able to give him time to prevent what he was able to say. We'll make this presentation available to everyone afterwards, and I can even ask Richard to do a little bit of a write-up to state what he was going to say at the later half here as well. So thank you, Richard, and sorry we weren't able to figure out the connection issues, but I really appreciate having a community member on here from Africa to talk about their community response to COVID-19 and within harm reduction, because obviously that points to how strong peer leadership can be when it comes to drug policies and on decriminalization as well. So thank you, everyone. We really appreciate all your presentations, all the speakers as well. So we only have a couple more minutes here until the top of the hour, and we recognize people have places to be and things to do as CND continues this week, but I wanted to make time to just address a couple of questions. And then one thing I neglected to mention at the beginning of this as well is we have a short 2.5-minute video to display after the Q&A by the Office of the High Commissioner on Human Rights on decriminalization. So obviously, if you have somewhere to go, please don't let us hold you here, but If you'd like to stick around, we would still love to have you contribute to this discussion. So the first question I'd like to pose to all the panelists, and it's one that is being asked both a lot in the chat and in the Q&A, and I think is a very natural one to follow up this entire presentation, is how can we bring more attention and community responses towards decriminalization, particularly in EU countries which have far-right governments, Poland, Bulgaria, Romania, Greece. And really, if this is the reality of where we are with decrim, where do we go from here and where do we need to focus our efforts and our energies? So I would love to hear the response by any of our panelists towards that question, because I think it's a really important and a really big one.
Okay, well, it's Annie here. I mean, just, I guess, sort of some initial thoughts on the, probably more the last part of the question, Jake, around sort of where to from here, because I did notice that in the chat. And I think it can be quite, you know, natural enough to sort of feel a bit sort of defeated by some of this sometimes, you know, but actually I think what the INPUD report really shows and the research behind it is just how important it is to start doing our own research to get our voices heard and to get these issues out and on the table. And the work in Canada, I think, is really showing as well, just the importance of the you know, the meaningful involvement of people who use drugs and partnerships with other civil society groups to really start to sort of build the voice at the table, you know, at wherever those tables are, and in various countries in different ways and different processes, and at the UN level as well. But it's just really important that we see this as a starting point, you know, because that was part of the thing for the INPUD research, is that our voices hadn't really been heard on this issue before, you know, and so there's so much more to be done here, and we're just sort of scratching the surface. And I think we need to use this as a launching pad. Yeah, I think is what I'm trying to say, to, you know, get more conversation going on this whole issue of, as Richard's presentation pointed out, you know, what is decriminalisation? What are people, you know, what's meant when that term is used? Let's get some clarity around things, and let's start talking about some of the more complex issues here.
Wonderful. Thank you so much, Annie. Anyone else would like to respond to this question about where do we go from here and where do we take this information in terms of our advocacy?
Could I try?
Yeah, please go ahead.
Just some small remarks. I think this is a process that already has started. So in a way, the snowball has started to roll, and it is to follow it. What is one of our experiences is to say that we have been looking at Portugal, because once you start to talk about decriminalization, for many it is a huge step, and many people are scared to say, well, what will happen then? So I think that for every nation that do so, we need to learn from them to see what are the experiences, what are the results. Will the number of people who use drugs, will it increase? Has it increased in Portugal? What has been there? So I think that to learn from them and to have very good data is very important for others to, when some takes the first step, for the others to come behind them and to learn from them and say that, well, it didn't, excuse my language, it didn't go to hell, and then maybe we could do it as well. Thank you.
Thank you very much for that, Torbjörn. So there's two questions here directed to you, Laurel, which I would love to pose to you before we wrap up here, because I think they're particularly relevant with given UNAIDS position. So the question is to make us basically, how can UNAIDS help make clear to governments what the meaning of harm reduction is and how that links to HIV and Hep C prevention, and how to really help get harm reduction programming moved and supported by local communities and within local budgets, particularly in the ECHA region, as there's been a lot of lost faith over the years in funding for harm reduction services and the availability of that. So I don't know if you can maybe speak to a couple of points in the strategy that maybe touch on availability of funding, but I think that would be great to touch on.
Yeah, no, thank you, and thank you to INPUD and Olya for the questions. Really critical questions. I think there are a couple different approaches to in terms of how we can respond and support. I think starting sort of at a bigger scale with the strategy and the new global strategy that we now are charged to take forward and implement as a globe, but also UNAIDS as a secretariat for the joint program. We do have strong language, as you know, in there on harm reduction and drug decriminalization, including the provision of naloxone and including the need for supporting communities. In fact, that 80% of key population, prevention for key populations should be led by communities, which means that 80% of harm reduction and other prevention, HIV prevention programs for people who use drugs, people who inject drugs, should be led by and for the networks of people who use drugs and people who inject drugs. So I think that this is a strong advocacy tool, but it's also a tool for educating governments, for UNAIDS also to educate governments about what's actually needed if we are going to reach the goals of ending AIDS by 2030. So I think that's the first place to start. In addition to that, in the global AIDS reporting, the GAM reports that come out, the governments report their progress toward meeting commitments in the GAM, their commitments on HIV in the GAM. And the GAM has very clear criteria for what harm reduction services are and should be offered by governments. And so there shouldn't be any confusion about what is considered harm reduction services. There may be willful confusion, but the information is out there. And then finally, we are able to offer some technical support through the funding we have to provide technical support to remove barriers and blockages in the implementation of global fund grants. So for countries that receive global fund funding, we can help provide some technical support to work with the government on harm reduction services and packages of harm reduction services that should be offered and how to best implement and deliver those. So I hope that's helpful, but there are a few different mechanisms and ways that can be used to support this. Thanks.
Wonderful. Thank you so much for that, Laurel. So I think we have time for one more question, and then we'll share the video with everyone. So there's a lot of great questions here, and I'm sorry we don't have time to get to them all. Hopefully some of them, we can continue this discussion on other platforms. There's a really good, I think, timely question here that I think would be great to address. That if some of the panelists can speak to the intersections of racial justice, since not only does drug criminalization disproportionately impact marginalized and racialized communities, but for example, in the US, many programs of research are traditionally geared towards white cisgendered men, which create further stigma for these groups. So could any of the panelists, and Richard, I saw you typed a response, maybe you could lead us off and give us some thoughts, Richard Elliott. How do you address this in research and conversations with folks with lived experience, particularly folks who have experienced stigmatization or race-based violence?
Sure, I'm happy to say something very brief. I did put an answer in the Q&A box, just to note that the racism of drug prohibition as it's enforced in Canada, at least, but not just Canada, is something that I think most people who are involved in drug decrim advocacy here are certainly aware of. It's absolutely a problem that we have limited data, unfortunately, but the data that we do have about the enforcement and impact of prohibition is indicative of a problem, that decriminalization is a racial injustice, and that therefore advancing decriminalization needs to be informed by a commitment to racial justice. And in the development of the common platform that Canadian civil society has been working on for a number of months, through a number of different rounds of outreach and consultation, there is also a conscious effort to reach out to Black and Indigenous organizations in particular as the populations most affected by prohibition, and that obviously needs to continue, and it needs to be always brought forward in our advocacy about one of the ways in which decriminalization is really harmful, and one of the very strong arguments for why we need decriminalization. It's part and parcel of that advocacy, and I think it needs to be.
Thank you so much for that, Richard. Really appreciate that. Last call to any of the other panelists to give a response to this question before we move on. Great. Well, thank you all again so much for your wonderful questions. And sorry again, we couldn't get to them all. We are pretty much at the events, the end of the events at this point as well. So thank you everyone for sticking around. Like I said, we have a short 2.5-minute video that was shared to us by the Office of the High Commissioner on Human Rights, which features a community member from Malaysia, Yedi Jonet. So we would love to share that video with you guys right now just to end this event. And thank you all again for coming. And I just want to remind everyone that we'll be making the recording of this available online afterwards. And we'll also be emailing you a packet with the INPUD decriminalization report, as well as all of the presentation slides for our panelists. And I will ask Richard from INPUD if he could maybe please share a few comments typed up for you all as well, since I am sorry we were not able to fully get to his presentation. So thank you everyone again, and hope you enjoy this video.
My first taste of drug is when I'm 15. I involved with drugs problematically for 20 years. I was sentenced to prison for 2 times for a small possessions of heroin during that time, and 2 times to rehab center. And actually it doesn't stop me from using, as I'm currently using.
The so-called war on drugs is given by the idea that crackdown on people who use drugs or who are involved in the drug trade, the drug problem will go away. 20% of the prison population now in detention for drug-related offenses, including for personal use of drugs.
People who use drugs do not forfeit their human rights by virtue of their drug use. And that in parallel, we ensure that their other rights are met as well, in particular, the right to the highest attainable standard of health.
We are witnessing, in some cases, increasing human rights violation related to the drug control efforts. This includes extrajudicial killings.
The fear of criminalization, of arrest, and of punishment acts as a huge structural barrier that drives people away from seeking health and harm reduction services, such as HIV prevention services, needle and syringe programs, for example, and has led to an epidemic of HIV amongst people who inject drugs globally.
With the criminal record that I hold as a prisoner for a small possession of heroin at that time, there's no way that I can do even e-hailing job. I cannot do Grab, or I cannot help others.
We are asking state to change to move from the punitive approach. Policy changes could also help the criminal justice system to take away the pressure from them only for this crime.
Wonderful. Thank you again for sharing that, Zaved. And like Zaved just noted in the chat, this will be uploaded on social media on the web on Wednesday. This video, I mean. So thank you all again so much for your time attending this event today. Thank you all to all of our wonderful speakers for your presentations. We'll make all this available to you, everyone, and to everyone else. Just have a fantastic rest of your week. Enjoy CND, and thank you all for participating.